Right, good morning everybody. Welcome to our April board meeting. I don't think we have any apologies for absence. Does anybody have any interest they need to declare? Excellent. So that takes us to the minutes of our March meeting. Is everybody content they are a true and accurate record of what we discussed and agreed? Good. Thank you very much. Take that as approved. Miraculously, there is nothing outstanding on our action log, which is great achievement. Is there anything else that anybody wanted to raise as a matter arising that's not otherwise on our agenda? Okay, so swiftly we move on, David, to your report.
Thanks, Peter. Good morning, everybody. I'll do this in two bits. If we do the performance report and the pattern that we've had over the past few meetings, our colleagues around the table will pick up some of the key issues from the performance report, and then I'll come back and I'll whiz through the other items, Peter. So on terms of performance, again, we've separated the introduction into those that are on track and those that aren't performing to the plan that we've got. You can see on inspection frequencies, good progress is being made. National Customer Service Centre, good performance that are being made. I'm not going to dwell on this, but on money we're underspending. On registration, we've got a strong performance, particularly in the context of increased volumes. NCSC is performing above plan. Safeguarding alerts after a dip are back to where they need to be. In terms of volumes of inspection, we're performing strongly, but there's key issues related to recruitment, and that recruitment pipeline has beginning to work. The perennial challenge around inspection reports and the time, again, you've got the up-to-date data as we continue, and colleagues continue to work on that. And whistleblowing data is in here, and we've tried to separate this out into priority 1 and 2, 3 and 4 to give you a sense of the priority that's given to that information when it comes in. And this is a monthly performance report, so this is a reduced performance report given the one that you get quarterly. But the annex is attached to the report, which has a more detailed analysis in that informs the covering report. So if I pause there, Peter, and if colleagues have questions, I'm sure ET colleagues will endeavour to answer them.
Mark.
Thank you, Chairman. David, I just wonder if I could ask a couple of questions around the sickness and turnover data that's listed there. I mean, looking at sickness, we have a target of 5%. Digital NHS tell me that the NHS average is 3.8%, with quite a large percentage of musculoskeletal injuries leading to absence, which I'm sure our staff wouldn't have. And the UK average for absence, according to ONS, is 2%. So I'm asking whether we've actually got the bar at the right level based on our performance over the last 12 months, and perhaps more importantly for us as a board, whether there are areas where there are outliers, and that would be a more interesting picture for us. That's my first question. The second question, if I may, is about turnover. Again, that's an average, and I wonder where we have outliers, and if that's a cause of concern, particularly in turnover. Usually there's the challenge around turnover in the first year or second year of service, so the churn. And we have a big recruitment campaign on at the moment for inspectors, so whether that would be of more interest to us, where the churn rather than the straight average. And then thirdly, in terms of recruitment that I've referred to, it's a key measure of organisational effectiveness and performance, and I wonder whether we shouldn't be recording average time to fill. Okay. Thank you.
So on the sickness and the 5%, we'd set this. I'm not quite sure it is a target. I'm not sure I want people to have an ambition to have 5% of our workforce being sick. If we were to set a target, I'd prefer we set it at 0. But I think what we've got. Sorry.
It's a line.
It's a line, yeah. And but I think what we've got here is the record of our sickness average over a period of time, which has been pretty static over virtually all of my time in CQC, to be honest, Mark. If you were to look at our, going back to one of John's early points, trend analysis over last year and the year before that and the year before that, I think it's going to come out at this 3 point something percent. We can break that down, and each directorate gets a much more broken down by directorate, and then within directorates it's broken down even further. So I think it now goes down to each inspection team in the inspection directorate. So we keep this information in quite a granular fashion, and that goes back to managers at different levels through the organisation. So if there are spikes, long-term illnesses, we've got an older workforce, a predominantly female workforce, that will generate particular kind of long-term sickness issues that we've got. We do get musculoskeletal issues. You'll see a lot of inspectors who are working away will now carry briefcases which are on wheels because of the amount of just the computers, the weight of the computers. People that have been doing the local strategic reviews will have quite a bit of data with them that they'll be carrying. So the musculoskeletal stuff is there. But if you wanted more information, Mark, I'm sure Ruth Bailey, as Director of People, would make that available to you and get into that. Similar question on turnover. Turnover has been a tricky one because we've gone through a period where we have been expanding, we have been taking on more people, and but one of the issues we've had is people that have been in the organisation for a long time who have felt that the changes we've made are not for them. So we've had a number of people leaving because they don't feel comfortable with the changes we've introduced. These are people that have been regulating for 10, 15, in some cases 20 years, going back through our predecessor bodies, who in terms of some of our new methodologies have felt this is not for them. One of the issues, for instance, would be about report writing. One of the things inspectors would say is, this job would be fine if I didn't have to write the report. And actually the report writing is an inherent and integral part of the job that we have to do. So I think there have been people leaving because they felt the job isn't for them. Interestingly, your point about turnover in terms of the length of time people have worked for us, and actually being alert to that. As an executive team, we have had that report and monitored that through a period of time. This is a high-level report that we've not been through. And again, it is something that we look at because that allows us to reflect on, have we got the recruitment decisions right? Are we inducting and supporting people prior to them beginning to take up the heavy lifting of the job that they've come here to do is a key issue. So we are alert to that. I can't remember what the figure is off the top of my head in relation to this. And I think as a consequence of that data, we've spent quite a bit of time looking at how we receive people into the organisation. I hate this phrase, but they use the phrase onboarding. But there's a lot of effort gone into that about how we induct and support people, and I know there's a lot of effort, particularly for inspectors, gone in by inspection managers to make sure that process is done well and people feel supported well. And again, I'm sure Ruth would share with you the data, and we take that down. And then on recruitment, I don't know whether we do collect that, if I'm being truthful, the time to fill jobs. It's certainly something that I think has informed the policy position we've now got to, which is for inspection staff in particular to run an always-on recruitment. So instead of having recruitment campaigns which begin and end, we've adopted an approach which is always on, and that I think has been informed by the position that we've had about recruitment. We've also got variation in recruitment, so there have been some particularly hot or cold spots, depending on how you want to refer this. So recruiting adult social care inspectors, I think, in the South East has been particularly challenging. A lot of effort has gone into that, and I think those teams now in the South East are coming up pretty much up to full strength. But one of the reasons our performance on producing reports on time and doing the inspection programme that we've flagged in that South East corner has been down to workforce. I've visited teams more recently where there should be 8 inspectors and they've been operating with 3. They're now up to strength, and so I think probably last month saw them start with 8 inspectors in a team that should have had 8 inspectors for the first time. So I think we are taking action in relation to this, but I'm just, do you know if we have time to fill?
So it's one of the things I've asked them to look at because it helps us around both forecasting of our finances, but also in terms of forecasting of our resource profile. So they are now on with that.
Yeah, thank you, David. I am actually meeting with Ruth, so I'll follow up a lot of those items. Thank you.
Anything else? Lewis.
Again, on the issue of improvement, which we talked about before, but this relates to the report data, and it's page 23, I think, of the report information. I think it's 23. So it's where we see the change in ratings on re-inspection. You see what I mean? It looks like it could be 24. It's slightly difficult to tell, actually.
We've got 2 reports. One has 9 pages, the other has about 12.
It's slide 9 in the.
Oh.
You're looking at something we haven't got?
No,
Because it's the bottom right-hand side. If you do the numbers of pages in the whole thing, it gives you that, but it's slide 9, I
Okay,
think.
it comes up as page 24 for those who are looking at my version of it. But it's the question is not what page are we on, but the issue of improvement. Because maybe that I've missed this before, but it just looks like we're getting an increasing divergence between sectors on how much improvement is occurring on re-inspection. And now, obviously, there's the question of how many re-inspections this is based on and so on. But if you look at the third slide, the third graph there, that's C, ratings change for previous requires improvement. And say compare the mental health trusts with the acute trusts. So the mental health trusts look like they respond on re-inspection, quite likely to get a rating of good, whereas the acute trusts, that's not true. I think that's probably always been true in primary and PMS. But it just looks like the acute trusts are being slightly left behind. So good for mental health trusts. They're doing very well. It looks like they're improving on re-inspection. A question over acute trusts. And when we look at these things, we tend to say, well, that's partly because of the complexity of acute trust overall ratings. They're aggregates, they're based on a number of locations, and because there are so many locations in an acute trust, that slightly counts against an upgrade in overall ratings. But that's not really true here, because the locations figure, which is on the same graph, is more or less the same as the overall grading figure. So it does, and if you then look at what impact that has on graph A, you can see that we've now got quite a disparity between sectors on how likely you are to be served by a good or a requires improvement trust locally. And the acute sector is the only part of the system now where you're more likely locally to have a trust with a rating which is below good. It's the only sector. And so mental health has improved, social care has improved, but the acute sector, I think it has improved, but just quite obviously less so. And so now, is this real? And are you, I suppose, Ted in particular, are you getting a sort of confirmatory feedback on this? What's your explanation for that?
Yes. Well, I mean, I think it's real, Lewis. I think we are seeing improvement in all sectors. We're seeing more rapid improvement in mental health trusts than we are in acute trusts, and I think that is a real finding. I should say that we need to recognise the pressure the acute sector is under at the moment, and has been for a while, and it's increased over winter. And I think it's 20 trusts in total moved from RI to good in the last year. which I think is quite an achievement when you take into account the pressure they're under, and I think we need to celebrate and congratulate them on that. I think there is a residual.
That pressure exists in mental health as well.
I think we need to there is an issue with a significant number of trusts that are stuck at RI, and I think that is becoming an increasing evidence. And I think there was a sense when RI was the most common rating for trusts that I think some trusts felt comfortable in that space, and it's very clear that some trusts have risen to the challenge of improving their services despite the pressures. Other trusts have, if you like, focused too much on the operational pressures and failed to see the necessity of improving services overall. And we'll be challenging those trusts, and we're increasingly challenging those trusts that are stuck at RI to follow the example of those that have improved. So I think different sectors are moving at different speeds, but they are all improving. I think the challenge to the acute sector is, despite the pressures it's working under, to keep driving improvement. And I think, many trusts have shown they can do that, but some trusts still need to demonstrate it.
Anything else for the performance report anybody wants to raise? Okay, David, onwards.
Thanks. So I'll do this next bit quite quickly. So just wanted to draw attention to the board in public session that we'd submitted evidence to the Housing Communities Local Government Joint Health and Social Care Select Committee, where they were asking for evidence on the inquiry into the funding of long-term funding of adult social care. We drafted a paper that's been submitted as evidence that went up on the website and is now on CQC's website. And next week, Andrea will go and present evidence to that committee. The published paper will shape and inform the evidence, and I'm sure there'll be a healthy discussion at the committee that Andrea will be able to contribute to. We've also published a response to Health Education England's consultation on the draft health and social care workforce, which is a pretty important document that is being developed and drafted, and again that response is appended to the report, and I think one of the key issues signalled by the Secretary of State is he wants this to address social care as well as the NHS workforce, and again we've made a contribution to that given some of our inspection findings and the comments we've made in the State of Care report. Next paragraph updates you on the fee scheme and the introduction of the fee scheme. The Secretary of State made a decision to support the proposal that we put to him in relation to the fee scheme for 2017-18. Peter and Andrea met with the trade, some of the providers in community adult social care services and the trade body United Kingdom Home Care Association, who had some concerns about the increase in fees that were coming through to them. It was part of a 4-year transition to full cost recovery on the fees for this sector. This is, I think, the third of those years going through. But members of this sector were concerned about the significance of the fee increase. We'll continue to work with them, and Andrea and Peter will meet further with UKHCA later this year, and we'll need further discussions as we go through the year with them. So I don't think this is a one-off, but we just wanted to mark both the decision by the Secretary of State and the concerns that were voiced by UKHCA. Just on updates, the work on the thematic review on Never events has begun, and the teams here, led by Ted, and I think Robert, I think you're the non-executive sponsor for this, have begun this work, anticipating an interim report in the summer and a final report in October. Just also wanted to acknowledge the announcement by NHS Improvement and NHS England of their move towards making joint appointments, particularly at a regional level, and will continue to work with both organisations in relation to that work. On the 1st of April, we saw 10 areas of the country designated as integrated care systems and be part of the development of healthcare services working much more collaboratively in geographical areas. And the issue this raises is, what does that mean for the way that we regulate health and care services when they're behaving much more as a system rather than as separate organisations? And what this paragraph is attempting to do is just update the board on some work that Malta's been leading, which is to get a connection with each of those 10 sites with a senior colleague from within CQC, and the proposal that we work much more closely and in detail with 2 of the sites, where we're having a much more in-depth conversation about what does the implications of the way that they're working have for the way that we're going to regulate in the future. We've got a strong basis from the local systems reviews on which to build, but it does allow us to work in real time to develop our thinking. The other advantage of linking people and working in 2 areas is that that becomes something that's not just done at a senior level, it's actually done by managers and practitioners in the i.e. inspectors, analysts, etc. So we've got some real-time development. Following the Salisbury incident and the issues around cyber security, I guess there's been developments since this letter came from the Department of Health. We've been asked to again review our security procedures in relation to cyber attacks, etc. I think there have been warnings as recently as this week as well in relation to this, and just wanted to provide some assurance to the board that we again continue to pay attention to this area because of the importance of the security of our systems and needing to attend to that. Because we have external providers of a lot of our systems, this has largely consisted of actually seeking assurance and reassurance from the providers that they've taken the appropriate action to mitigate risk from cyber security. Now, I'm not going to dwell on these, Peter. We're just flagging publications that we've made, approved mental health professionals, the state of independent healthcare, driving improvement in mental health trust, and a shared view of mental health, a shared view of quality in general practice. And we're due to publish, before our next board meeting, a report on driving improvements in GP practices, which play to this point about what contribution are we making to improvement, not just at an organisational level, but at a system-wide level, which plays to the conversation we've just had about the research paper, I think, which I personally think is a hugely important contribution that wasn't really flagged about how we do these systemic reports. But that's the report. Thanks, Peter.
So, as always, there's a lot going on, and you've gone over the ground well, but quite quickly. Do people want to come back on anything that's in there? Lewis.
Thank you very much. Can I ask about the Never Events review? The Never Events, I have to declare an interest here because there is only one Never event in mental health, as I understand it, and that comes from my research, which I did about 15 years ago. So that tells a story here. We haven't been very good in mental health at being able to develop a sort of a more up-to-date and practice-relevant set of Never events. And part of that may well be that the model was derived from acute care, where there was something you could do, and then the consequence would never happen. And in the complexity of people's lives in mental health, that's quite a difficult thing to say, because is there something an intervention you can apply, and then a tragedy will never happen at all? Very difficult. And so I hope that, and that's played out in quite an important way recently, because you may know that earlier this year, about 2 months ago, there was an announcement by the Secretary of State about suicide on inpatient wards, in which there's a drive now to, at the moment there are something like 85 to 90 deaths by suicide of mental health inpatients every year. That's quite a lot less than there were 20 years ago, but it's still 85 to 90 people. And the question was whether we could drive that down to the point where it was zero. And there's quite a powerful movement in mental health called the Zero Suicide Movement, which was behind that. And one obvious route through which that might have happened in the existing system was the never event system. So you take this zero suicide message, turn it into the existing never event model in the NHS. And for various technical reasons to do with the definition of a never event, that wasn't possible. And so we got a separate announcement which stands outside the current system. And I think there is a question here whether that's really serving people well, and whether the model we've got for never events is one which is helping improve safety, certainly in my specialty. So I don't know whether you'll be in a position to comment on that wider issue. But I think in trying to understand how well they're working, one of the questions is what's not on the list, and that could be.
Well, it's too early to draw any conclusions about what our recommendations are going to be, but I think it's important to emphasise that the reason we're doing this review is that never events have now been, I think, 5 years in action, and the number of never events has not fallen. So there was a kind of assumption at the start that these events were preventable, and if everyone did as they were told, they wouldn't happen. Well, patient safety isn't that simple. It's much more complex than that, and we're trying to understand what are the barriers that stop these apparently preventable events from being prevented, and that's fundamentally what we're trying to do, and understand that, if you like, that dynamic. And that is really fundamentally at the heart of patient safety, because it won't just be about never events, it will be about other safety guidance as well, such as the issues you're talking about. So whether we should extend never events, is certainly an open question, but whether we're going to move in that direction or not, I think is much too early to judge. I think we have to focus on what is it in safety guidance and in the practice and the implication of that safety guidance that makes it truly effective and prevents patients coming to harm. And I think that is the fundamental question we're trying to challenge here. And it is a fundamental question about safety, and it relates back to the work we did last year on learning from deaths, for instance, where there's a similar question asked: how can we learn from things going wrong to improve safety going forward? And I think that's a fundamental challenge in the healthcare system across the board.
Just very briefly, Peter, can I just ask? Thanks very much for that, Ted. The timescale looks quite, as timescales always are, tight. So an interim report in the summer, a final report in October. That sounds like some big questions have to be addressed between now and then. Could I just ask you that would come back in some way to the board, because it's quite an area that we should all take quite a strong interest in, I think.
I think it's a very important area. We are on site at the moment inspecting hospitals as part of our routine inspections, looking at how they're implementing never events, learning from what works for them and what doesn't work for them. And we are consulting a wide spectrum of experts from across safety field, not just in healthcare, but across many other industries as well, to understand what's worked in other industries. So at this stage, I think it's too early to judge. It is a tight timescale, but it's an important issue. I think if we can really fundamentally change our approach to safety events, it can have an enormous impact. So I think it's very important.
I thought I'd done it. Sorry. Thank you. So yes, I think it will come back to the board. I think there will be an interesting set of learnings that will come out of it. So I'm not quite sure which month. I haven't got my mind around that yet. Well, no, I think it comes back after the report, rather than that was what I was thinking.
I think the interim report in the summer will just talk about progress, not conclusions. It'll be the autumn before we reach any conclusions.
Yeah, so it'll come back at some point. Yeah, but, David.
Well, just on the process point. All of our thematic reviews, I think, have been sent out to the board and allowed comment before it, because we otherwise get into this. You're either racing to get it for a board meeting or you're slowing it down. But I think the delegations say that I signed them off, occasionally with Peter. But I think on the last few, the CAMS report came to the board, I'm looking at etc., and you all got the opportunity to comment. Whether it comes to a meeting where there's a discussion or not is another issue. But given your experience and what you've said, I've got huge sympathy with the point you're making, Lewis, about suicides. I'm absolutely with you on that. I think we should work out how we're going to get that in the way that we have done with the other thematics, which is draft report, letting you have some sight of it, rather than we're then trying to launch things based on an agenda. The October one will be a lot easier to manage than the summer one, I suspect, but we'll make sure it happens.
Robert.
I just wanted to say two things. Firstly, a lot of very impressive work is going on this at speed. And secondly, that it is a very profound subject. And, the observation I would have had before this review is that the Never events are a very peculiar variety of things to which different responses might be required. Certainly, at the time of mid-staffs, it was the alert system was bureaucratically reacted to, with the result that the alerts never seemed to get through to the people who actually needed to do something. And if this review has at least changes that would be an encouraging thing.
Good. Liz.
Thank you. Sorry. I was interested to see our response to the Health Education England's draft health and care workforce strategy, and particularly drawing on our learning from new models of care and not having an overemphasis purely on hospitals and the role of social care, etc. All very good stuff, I thought. It mentions in there the potential of new pools of labour and the importance of looking at new pools of labour. And I just wondered whether we've done anything to sort of join up that thought with some of the work we do in another sense, which for in relation to some of our work, we do look at employment outcomes. For example, looking at recovery-focused practice in mental health, employment outcomes are one of the things that we do look for in inspections and are looking at mental health services. We've also got a workforce disability equality standard coming in throughout the whole of the health NHS this year. And I just wondered whether there was I'm not suggesting for a moment that everybody who's using health and care services wants to work in health and care, but health and care have a role in enabling people living with health conditions to work, is my point. And there is a labour pool about which health and care have some influence and a lot of contact. And I just wondered if we joined those two thoughts up.
So, Andrew, do you want to hear that? No, not to respond. I mean, just literally to hear what Liz was saying. I was going to make a different point on this, which is, and I think our response almost gets there. But there's, if you're trying to work out what workforce needs you're going to have over the next 10, 15, 20 years, it's impossible, because there are we don't understand and can't understand at the moment the impact that technology is going to have, and what skills therefore we will need from our workforce in the future. And it seems to me anyway that the very big part of what needs to be thought through is how do we equip the workforce right across the spectrum with skills that are transferable, so that as technology takes away some of the existing jobs and new jobs are needed in response, we've got that flexible workforce. And I didn't think that we almost get there. We talk about are we going to have a need for more general physicians rather than specialists? But I think it's much wider than that. I think it's across the entire workforce. It's not the same point that you're making, Liz, at all, but it was the point that I was going to make. And it seems to be, if I was trying to design a workforce strategy, apart from panicking at the thought of it, that would be the thing that would be most in my mind.
And I'm just on that. The flexibility, the necessary flexibility, is very, very powerfully cut across with the inflexibility of training. So someone in this September will be going in, and 12 years later they'll come out a diabetologist. Now, that is just very odd, given the nature of the needs that will be there in 12 years' time. So we have an incredibly inflexible training system for what is everybody intellectually knows has got to be an incredibly flexible workforce. And seems like no one's doing anything about that. So every year that continues and probably expands. So when we talk about expanding for the future workforce, we'll primarily end up expanding in flexibility when everyone knows we need more flexibility. But I think there's another and really quite important point. This is one of the biggest industries in the country, maybe the biggest industry in the country, health and social care. And everybody goes around saying there is a shortage of labour. And everybody, by and large, when they say there's a shortage of labour, is looking away from where labour is and looking in directions where labour isn't. And so actually there are lots and lots of people engaged with health and social care who would love there to be a ladder of opportunity. And the ladder that exists has several rungs not in it, including where it reaches down into. And so there needs to be something beyond, exactly as Liz was saying, the way in which we continue to replan and replan and replan, as you said, a mug's game, given we can never know what's going to happen, and actually start saying, what have we got in our society? Where do people want to work? How do we then reach those people? Because people would love to work in social care and the NHS, and we construct barriers that stop them from working here, and then we say there's a shortage of labour. Robert.
Well, why don't we just take from this conversation and capture that and then set out a supplementary letter back that captures the points in addition to, I think, some of the points about the difficulty of forecasting, etc. I don't think we made that point, Liz, but is it connected intellectually? I think it is. Practically, who's doing what in relation to that, I think is a different question. I'm sure there's examples where people are doing that, but I don't know that's the norm. I think that's what you and Paul are both saying. So why don't we take from this conversation and get a supplementary letter to go in on the back of what we've sent in and make sure that the comments of the board are captured as part of the consultation. It's just a practical way to deal with it.
Thanks. So Robert and then Steve.
One thing the strategy does deal with, but our letter hasn't, but it's no particular criticism, but it is something I think we can do something about, is workforce retention insofar as it is influenced by the working conditions in which staff at the NHS in particular, but also adult social care, have to work. There was a recent survey done of trainees of the Royal College of Anaesthetists, which indicated very high levels of concern about lack of facilities, really basic facilities in which to work, like places to eat, places to rest, all those sorts of things, which, if they persist, particularly in an era of financial shortage and staff shortage, will lead to people leaving. And there is evidence of both doctors and nurses leaving after pretty expensive training. Now, it seems to be that Health Education England undoubtedly has a role in this. We, as the Inspectorate, also have a role in when we're looking at whether a place is well led and whether their staff are being looked after. And I just wonder whether that's something we could consider. I'm not saying we don't consider it, but whether we should consider it more overtly.
Steve.
Thanks. So the local system review summit meetings, the feedback meetings we have, it's the single most common question that I'm asked, and the most common assertion is about workforce issues in whichever area. And it's usually about nursing and people working at the lowest levels financially in the health and social care system. Those who are giving care in care homes, nursing homes, domiciliary care, are often paid, or usually paid, the worst of any care worker. And the problems, for example, in Oxford, were around how do you recruit people when you've got London prices without London waiting, with an inadequate supply of housing, through to Trafford where we were, where you've got a massive retail park, and as soon as a supermarket opens or a new shop opens who pay more for less responsibility, why wouldn't you move, or about attraction? And so we talk a lot about that, and I think if you read our reports, in most of the reports, those who are not doing very well from delayed transfers of care and care of the over 65s, there is a lack of a workforce strategy locally to look at the whole workforce. the headlines are about lack of GPs and doctors often. But in reality, it's at the bottom of the pyramid of workforce where the greater care happens for the least money. And it's that comprehensive workforce strategy which is necessary. One little bit of good news to finish on, because I know you want me to shut up, is in Dudley, where I come from, which is a poor area in parts of the West Midlands, where we went to congratulate an outstanding surgery in a very difficult area. And what they said, I went into the room with the management staff and talked to them, and I just asked why they wanted to work in this sort of surgery, and they said, well, it's rated outstanding, and that's really important, and we looked for their rating. And I said, well, what was your background? And the first person said, well, I was at hairdressing college. And I said to her, the person next to her, well, what was your background? Well, I was at hairdressing college. And I turned around to the third person, who was much older, and said, oh, well, you're not a hairdresser as well, are you? And she said, well, actually, I was. And it's an important thing, because the aspirations of some people in this country at school are for those sort of careers because they have more contact with them, and they're perceived to be stable, and the income is often better than the care workers, where they have no access to and they don't know what the careers are. And so the sort of thing I was feeding back into places like Hartlepool was, if you're going to do a workforce strategy, you need to look at the whole thing from junior school onwards, and see health and social care as a career to aspire to. And I think we have a responsibility of a regulator to do that. But the good news was the rating of outstanding in the practice helped the lower end of the workforce look to aspire to work there. And we have other examples where they have succeeded in recruiting doctors and nurses when before they were rated outstanding they couldn't. So that is a positive impact, given the theme of today is what's the impact of CQC.
Thanks, Steve. Andrea.
Thank you, Peter. And just to respond to Robert's point about the questions that we ask on inspection about well-led and how staff are supported, and that absolutely is one of the key lines of inquiry, both in terms of whether staff are safely recruited. Do we have enough of them? Are they recruited properly? Do they have the training and development to allow them to have the capability and confidence to do the job that they need to do in the circumstances that they're working in? And secondly, what is the culture? Is it inclusive? Is it open? Is it supportive to members of staff so that they feel engaged in the development of the service and feel aligned to it in a way that actually makes them want to kind of give more of themselves to it, and it helps to support retention as well. So they are key questions, and they are some of the areas that we find difficulties when we go into services, and it is something that we have highlighted both in response to the questions, is the service safe and is the service well led? So I think it may be one of those things that as we go forward, we could be, we've talked today about some of the thematic publications that we've done. I'm sure there's probably quite a lot of evidence within the depth of our reports that identifies some of the good things that providers have been doing and some of the things that providers should avoid. And maybe one of the things that we can think about is whether using our independent voice, that's something that we might want to exemplify more in a more thematic way.
And just to support that, I mean, just in my casual visits to providers right across the spectrum, I've seen some fantastic examples of how staff have been supported in lots of different ways, and I've seen some examples where there's little evidence they're being supported at all. So, it's a really big point. John, you wanted to say something?
A very quick point. What hasn't been brought out here is that the sustainability of health and care systems will struggle unless we embrace the users of the system as part of it. They have the maximum amount of time they have to look after their own conditions. And for that, you need the workforce to be systematically trained in how to do co-production and co-management, which currently they aren't. And I wonder if you'd consider adding that to the supplementary letter.
Perfect. Good. Are we happy to move on? Mary, welcome. Sorry, we've kept you waiting. We've denied you the opportunity to speak up for a little while, but now is your opportunity. So very nice to see you. Thank you.
Well, thank you. Thank you, and thank you for the opportunity to provide a verbal report ahead of my presentation of the annual report, which will happen in June. I am the CQC Freedom to Speak Up Guardian, and also the day job as a Head of Hospital Inspection, currently covering South West and South Central on the acute side. I'd like to cover 3 areas, and then I'm very happy to take questions. I'd like to give you a brief update on our arrangements. I'd like to tell you about the recruitment and training of Speak Up ambassadors, and also touch on my membership of a cooperative inquiry group, a group of folk I happened upon via Ashridge and involving tutors from Ashridge and the NHS Leadership Academy. So the arrangements, I was appointed after open competition within the leadership group at CQC, and I've had great support and encouragement from the hospital's directorate to fulfil the role, and also HR and the engagement team have been great support too. I work very closely with Henrietta Hughes as National Guardian and her office. They are a support of advice and guidance, and also I am part of the network of guardians from arm's length bodies. We take into account Henrietta's recommendations on the back of her annual reports and surveys and so on, and we check out a lot of the work that we're doing with them. In the day job as a Head of Hospital Inspection, I encounter guardians on inspection, and it's always my pleasure to interview them. And we're also seeing guardians as part of our regular 12-month engagement with trusts. And it's a great source of support and inspiration, meeting people doing the same thing in a different environment. We have revised our policy in line with the national guidance that came out from NHS Improvement in England, and we've also taken account of the best practice in trusts, and were pointed by the Guardian's Office towards a mental health trust in London as having what they regarded as the best of the policies. It's been a key thrust to get those policies out of the HR space, if I might describe it as such, and much more as a sort of open way of being as opposed to set prescribed procedures. Our revised policy awaiting sign-off. I've set up a reference group. I didn't like to fly completely solo on this, so I have a group of people from across CQC to support and challenge me. We devise a work programme together, they hold me to account, and I'm pleased to say all the equality networks are represented on that group, and we have a spread across the organisation. The National Guardian's Office has presented their report to you in the past and described the series of recommendations they've made for guardians. We've undertaken a gap analysis against that. I'm pleased to report we're in a good place, and there'll be more detail in my annual report about it. We have, as you would expect, intranet pages and a communications plan, and we run a number of campaigns to raise awareness of speaking up. It is not my ambition that everyone comes to Mary Cridge to speak up. It is my ambition that we are a place where speaking up is a way of life, where staff are encouraged and supported to speak up well, and when they do, that managers and colleagues respond well, and therein lies some of the challenge. I've mentioned campaigns. We worked around the National Anti-Bullying campaign that's been a feature of our public life for a number of years now and focuses on education. And we took the opportunity to run a week-long campaign involving our Dignity at Work advisors as well, who are specifically tasked to support staff who feel they are subject to bullying and harassment. I've had a number of cases and contacts with staff, and ahead of providing you with the figures and themes in the annual report, I'll say that they broadly reflect the experience of guardians in NHS trusts. Although there are safety issues that do come forward and things that are surprising, the vast majority are around behaviour and how atmosphere in teams and groups. We have had a couple of cases that have gone all the way, by which I mean to formal investigation, but those are a rarity, as they are in the NHS too. And success for me is when, on the back of a conversation, someone goes away and speaks up themselves and gets a good response. And when you see the detail in June, there have been some quite inspiring examples of that. I've referred to ambassadors. I couldn't possibly do this alone, and we have them at all levels in the organisation, including one round this table. So we have inspectors, managers, we have personal assistants, an executive, as I say. We have ambassadors from everywhere, strategy, intelligence, all the inspecting directorates and the corporate functions. And I'll come on to say a bit about that training in more detail. The whole purpose of them is to provide confidential advice and support, to be approachable, to listen well, and to role model. Our Dignity at Work advisors have all signed up to be ambassadors, and in the longer term we'll be considering whether we merge those roles as well. The training, we trained 38 staff last week in London and Leeds. This was delivered in partnership with the Academy and the National Guardian's Office. We reflected on some of the sayings of Michael West around civility, warmth, positivity and kindness having a place in our culture and in how we deal with each other every day. We reflected on what a great fit this all is with our CQC values. We also reflected on it's hard to do. If it was easy, we wouldn't be even bothering, would we? But it isn't. We looked at the barriers there are to speaking up. We understood the background. We had a very moving film featuring Helena Donnelly and Dr. Nick Harper, who I think you will all have met at one stage. We considered our role and activities. We tested ourselves on our listening skills, and we've looked at the support arrangements, because it's quite hard to provide support at times and keep oneself safe and positive in this space. I'm going to pause and invite Malta to just comment on the training.
Thank you very much, Mary. Well, for the one thing you haven't said that we did during the training, and as you said, it was really colleagues from all parts of the organisation and all levels, which was very exciting, was first of all how much interest and enthusiasm there is from our staff to take on this role and to role model the support to everyone else to speak up where people find it difficult or have less confidence as a result. And secondly, the idea that ultimately what you are trying to achieve, and what I hope I can help you with as one of the ambassadors alongside the others, is that this becomes a social movement in the organisation that changes the way that we challenge, that we speak up, and that we talk about how we can improve. This isn't just all about something that we're doing wrong as an organisation that we speak up about and have concerns about. This is also about speaking much more openly where we think can be done better. And as you say, if that turns into a social movement, then there might be a future where actually, as ambassadors and as guardians, we don't have a lot to do, but that is because everything else is working in the way we want. That's what we support. So I'm really proud to be part of it, and you're doing a great role in supporting that. Thank you.
Finally, let me mention the Cooperative Inquiry Group. So a cooperative inquiry is a group of people who come together with shared interests and questions and explore that together. And it will probably lead to a piece of published research. But at the moment, we are talking about speaking up, about the barriers to it, and about the examples of where it's being done really well. I was signposted to Professor Megan Rees, who is one of the tutors at Ashridge, and she has a group. There are about 6 of us. We meet every quarter and explore this. Megan published some research last March, Being Silenced and Silencing Others, Developing the Capacity to Speak Truth to Power, the key finding of which, and this was research-based, international research in both the public and private sectors, the key barrier is how leaders vastly overestimate how approachable they are. The workplace is very different now from when I started my first job. People are on first name terms. People communicate very well with each other. Dress code doesn't usually distinguish either, and it can be really difficult to tell from watching an interaction just who's got the power, but the people in that reaction understand who has it and who doesn't. And being more aware of situational and positional power is really important. Another aspect, and Michael West's research also touches on this, is the energy and courage it takes to speak up is usually a build-up to a point where the person, when doing that speaking up, maybe doesn't reflect themselves at their best or the values of the organisation. And as leaders and managers, there is a danger of falling into the classic trap of dealing with the behaviour and not with the message that's being presented. So my longer-term plans include training for all members at CQC, and particularly managers and first-line managers, in terms of encouraging people to speak up and then how to react well when they do. As I say, that's a sort of brief canter through what I've been up to, and there'll be a formal and fuller report in June.
So Mary, we look forward to the fuller report, but can I just say thank you not just for the presentation just now, but for what you've been doing, because I know you've put in a huge amount of energy. I dare say a huge amount of your personal time as well, and I think the whole organisation is the better for it, so thank you very much for what you've been doing.
Thank you.
Anybody want to raise anything with Mary?
Well, could I just say thank you very much for what you do, because it sounds from what you're saying that you've incorporated everything and more of what has been learned from the Freedom to Speak Up review, and it's only right and proper that we should try and position ourselves as a role model for the system generally. Thank you.
Thank you. Oh, sorry, you nearly got away there. Paul.
Just one credit. Mary, that's a really good presentation. It's really good to hear what's happening there. Is there anything else you need by way of help from this board or from others?
As you might imagine, I'm not slow to speak up when there are things I need. But that's a good challenge. I haven't got anything at the moment, but I will certainly give that some thought and maybe talk to you in June.
Okay. Mary, thank you very much again. It's really great. So, from the board, is there any other business that anybody needs to raise? So we've got about 4 minutes for questions from public who are here. I know, Robin, you've given notice of a question. Can I just ask, has anybody else got a burning question that they... Mr. Hogarth, how surprising. How nice to see you. Anybody else? So we'll just have the two. Do you want to go first, Robin, since you gave us notice of your question?
Thank you, Chairman. Robin Pike, Health Watch, Hertfordshire. This is a question relating to hospital inspections and to ask really how certain types of patient experiences which cross over all core services are noted in the course of an inspection. I have in mind particularly the pharmacy services, most of which are outsourced, many of which are outsourced in hospitals. And this can involve quite a task, really, for the patient, who's generally handed a blue copy and a pink copy of the prescription, the doctor having held the white copy. The patient then queues at a desk at the pharmacy in order to hand in their 2 copies and takes a ticket. The ticket is numbered so that the patient then waits for a period, frequently an hour, in order to obtain the medication. I understand that in primary medical services, many prescriptions are electronic. There are other experiences relating to the reception in a clinic, where in some hospitals the patient can register electronically on a pad. In other hospitals, the patient will queue in a corridor in order to see a harassed receptionist who is looking for their file, and that can be sometimes a lengthy wait. And finally, a mention of secretarial services to doctors in a hospital, where in some cases the secretary doesn't have their own desk or their own telephone because the secretarial services are hot desks, and consequently it's very difficult for a patient to contact a doctor's secretary.
Ted, I think he was looking at you as he was asking the question.
Absolutely, and I think you must have been following me, Rob, because you described my last experience when I picked up a prescription in a hospital. Exactly, almost exactly. And I think we're very well aware that some of these interactions at the front desk are very important for patients in terms of their experience of care. We certainly do look at these areas when we inspect. I think it's a real challenge from you that are we giving them enough priority, and I think that's something I accept and take away. We have pharmacists who go around with us in inspections. They look at medicine management, but they also look at the process. And one area you haven't mentioned, which I think is particularly of concern to us, is the delay in getting medicines for patients being discharged from hospital. Because not only is that a wait, but often it delays their discharge. Sometimes it delays their discharge overnight, and I think there are sometimes enormous delays in getting prescriptions for patients to take home, and that's something we've focused on and we have challenged trusts about. But the outpatient experience, a little more difficult to follow up, because we do sit in outpatients, we do watch what's going on, we watch on the interactions between receptionists and patients, and of course we talk to patients about it. And we talk to staff about it, and staff sometimes express great frustrations about those interactions. And we do reflect that where necessary in our reports, both under the key question of caring and also the key question of responsiveness. But do we capture it as well as we could? I think that's a challenge you're giving us, and I think it's a challenge I'm quite happy to take away. I think secretarial services are very important, and anyone who's worked in the hospital knows how important they are in terms of the patient experience. And I think sometimes we have challenged hospitals that, if you like, have downgraded the secretarial services and don't understand how important they are to patients in terms of their contact with the system. And sometimes it's the doctors who raise that with us and point out that actually the patient's experience is downgraded because of secretarial services, because the patient often doesn't understand why their experience is less than satisfactory, because they don't understand the internal hospital systems. And again, we have challenged that on occasion. Have we focused on it enough? I'll take that away as a challenge.
Good, thank you. David, can I ask you to be brief? No, come, please, and ask the question. But I was going to say, could I ask you to be as brief as possible in asking the question, which would just help us meet our timetable.
I'm David Hogarth, Neighbour Care, St John's Wood and Maida Vale. My question goes back to what Lewis was saying under the performance, when we were talking about performance, and about how it's more likely that a mental health institution will go up from requires improvement to good than an acute trust. Of course, these sort of comparisons are important, or only as important as the validity of the judgments that the CQC has made. And I really wanted to ask Lewis how satisfied he is that the judgments in the mental health area that the CQC are making are really valid.
So we have a convention, David, that this is not an opportunity to quiz individual members of the board of their views or anything else. So I think, can I answer the question by saying that we put in a lot of time and effort in reviewing and understanding the judgments that we're making. And there's a whole quality assurance process, because the central point is not whether services are improving or not, but absolutely the point you're making is can we have confidence in the judgments and findings that we make. So across all of the directorates, this is an important area. I don't think we've got perfection in this area yet. I think, strange enough, some of the technology that we will be adopting in the future will help us further. So it's a really important issue. We're on the case. I don't know whether any of my colleagues want to, looking at the chief inspectors, want to add anything, or whether that's a brief summary of where we're at. Ted, you look as if you want to come in.
Just to reassure you, there is a very rigorous process to make sure the ratings are consistent between one inspection and another. So I think when we demonstrate that a trust has changed the rating, I think that is actually quite a significant finding. And we have a framework to make sure that we're making similar judgments in different sectors. So we're very aware of those issues, and we have a process in place to control it. I'm sure Peter's right that we're not perfect in this regard, but these judgments are not made lightly without a lot of detailed study of the evidence.
So, David, can I just say, and I probably should have said this when Lewis spoke, I'm just trying to not speak on every item. I think Lewis's challenge this morning and your question is absolutely legitimate. It's a question I ask and ask of myself continually about how far is the performance report we present and the data in it a reflection of what we're finding or a reflection of how we're behaving, and how do we begin to understand that in a different way. So I don't think this is something we can give a ready-made answer to, but our hope, as well as the answer Ted has given about the quality assurance, how confident are we when we say this is good? It actually is good based on our methodologies. I think we've got stronger and better and more effective at doing that over the years. But I think the question that Lewis asked earlier today that you're repeating, just on Peter's lead, let me take it away from individuals. I think it's a question we need to continue to return to and continue to ask, because it's a hugely important question. Earlier today, we had a conversation in private session about how we evaluate the work that we do and how confident we can be of what we've found. And what I'd like to do is not give any kind of conclusions from that work, but actually say it's a hugely important part of our work going forward to make sure that we are able to answer those questions. Because it's not just you, David, that are raising them, and Lewis. I think these are questions that our stakeholders ask as well about consistency, etc. So it's a question that goes right to the heart of our credibility as a regulator, I think. Do we understand what's behind our numbers and what we're reflecting back? So I hope it provides some reassurance, Peter, that it's a hugely important issue. I wouldn't like to answer the question you just asked, Lewis, about, but I think it's right that that question is asked and we continue to work at understanding it.
So, thank you, David, for the question. I think that is the end. Board, you've got, according to my clock, 22 minutes before we start again. So, short break. Thank you very much. Thanks, everybody.